the first time we are coming across a molecule where the peptide is in a pill. So I would be talking how it got from lab to life. So this would be my agenda to talk you about quest for ideal anti-diabetic drug, the pioneer study, which is basically highlighted this particular molecule and the quest to put peptide in a pill, and then I would be summarizing my presentation. In quest, why do we exactly are in need of newer drugs despite our armamentarium getting fuller by the day? Because we need to maintain the tightrope walk between the hypoglycemia and off-target effects, and then weight gain and the desire to lower blood glucose. So once you A1C is around 7%, our expectation from newer anti-diabetic drugs is that not only we wanted to control the sugars, but it should also protect our heart, our kidneys, should be not associated with weight gain. And if there is additional bonanza of weight loss, that would be again coming in handy. And in quest for anti-diabetic drugs, you look at all the parameters. You compare the different drugs that we have been using, the sulfonylurea, the thiazolidines, AGIs, DPP4 inhibitor, gliptin, GLP-1 receptor agonist, and insulin. So look at the efficacy point. GLP-1 receptor agonist is high, hypoglycemia risk it is low, weight, there is a reduction and there is a cardiovascular benefit. And apart from that, look at the physiological actions, the number of paths it is actually acting upon. It is increasing insulin secretion, decreasing glucagon secretion, slowing the gastric emptying, and also increasing the satiety. So it again stands out as one of the tallest molecules that we have in our disposal. And the myriads of effects addressing 6 out of 8 octet mechanisms by the diffronzo. It acts on the liver, it acts on the heart and vessels, it acts on the brain, pancreas, GI tract, kidney, muscles. So out of these, we have 6 parameters which are being addressed properly by this GLP-1 molecule. But then the GLP-1 receptor agonists vary in the molecular structure and size. We have exendin-based therapy, that is exenatide and lixisenatide. These are short-acting molecules which are ideally better placed to target the postprandial hyperglycemia. Then we have the exenatide extended release once a week. Then we have dulaglutide once a week, and also the once daily liraglutide. The longer ones, the shorter ones, acting ones are the exendin-based therapy, and the long-acting ones are the dulaglutide and liraglutide, which predominantly affect the fasting hyperglycemia. And real-world clinical outcomes intensification with GLP-1 receptor agonists, what we find is that there is a significantly more patients reaching A1C target with adding GLP-1. Significantly more patients had no weight gain or more than 3% weight loss with GLP-1. Significantly more patients were able to discontinue more than equal to 1 OAD with GLP-1. And look at the composite outcome, which again is of very much importance. Significantly more patients achieved composite targets along with discontinuation of at least one baseline OAD. So the pill burden is going down, the composite outcome, the body weight, A1C, all of them are getting addressed in a positive way. Look at the multifactorial mechanisms. It acts on the insulin secretion, glucagon suppression, natriuresis, diuresis again is important. It reduces the appetite, and also the anti-apoptotic, the BCL2 and BAX2 are stimulated by this GLP-1. There is reduction of inflammation, coagulation, postprandial lipids, the left ventricular function is going up, the beta cell survival and function is going up, and also there are theories to suggest there is a potential neuroprotection. So what exactly the hard points that we are able to achieve? There is a reduction of A1C, reduction of body weight, reduction of blood pressure, CV events, hepatic injury, albuminuria. And for cardiometabolic benefits, as I was stating, we have become miser in our expectation from anti-diabetic drug. There is a reduction of all the 3 parameters of the glycemic triad, minimal hypoglycemia, reduction of weight, CV benefits are there, tolerable side effect profile, and approved for wide variety of patients. The wonderful talk presented by my previous speaker. Yes, we need to be aware of the limitations of the drugs. So what exactly has been done to put a peptide in a pill? The challenge is that, yes, the large molecule injections, fear of injection is still remain a barrier to use of GLP-1 receptor agonists for both the patients and the physicians. And if you look at the Global internet survey of 1,250 physicians reported having too many injections is associated with poor adherence to treatment in patients, where 26% of the doctors agreed. We had vial and syringe, then come the tailored engineered pen injectors, then oral form of tablet. And as we move further towards right end of this arrow, there is an increase in patient convenience. The rationale is that there is an unmet need for safe, non-invasive and convenient mode of therapy, where there would be increase in compliance and would expand the treatment options, early commencement of treatment, better patient outcomes, and that is the barriers associated with subcutaneous administration. So why it is challenging to give orally a peptide drug? First of all, there is enzymatic degradation in the stomach because of the low pH and the proteolytic enzymes that are in the gastric juice. Then we have limited permeability across the gastrointestinal epithelium. Apart from that, they have very low oral bioavailability. So these are the challenges when we try to give a peptide orally. So the Novo people, as we all understand, taught to us during our endocrinology days also, they are very good at attaching a fatty acid chain. So here what you can find is that the T half-life is 1 week with 94% homology to human GLP-1. The amino acid substitution at position 8, alanine to alpha amino isobutyric acid, protection against DPP4 degradation, and amino acid substitution at position 34, lysine to arginine, prevents C18 fatty diacid binding at the wrong side. And the fatty diacid chain to lysine at position 16 provides strong binding to albumin. It was a discovery which led to the path-breaking innovation in bringing GLP-1 receptor agonist in a pill. So this is the semaglutide, the most effective GLP-1 are tested to date. Long half-life of 1 week. We have studies where it is studied once a week therapy also. Then the SNAC, the sodium N8,2-hydroxybenzoyl aminocaprylate, is the absorption enhancer, which is tagged to the semaglutide, which promotes absorption across the gastric epithelium and enhances semaglutide oral bioavailability. And when you have these two in one pill, this gives rise to oral route of first-in-class oral GLP-1 receptor agonist, bioavailability if possible with an absorption enhancer, because the variability, if it is not getting associated with a SNAC, the bioavailability is low and the variability is in absorption is higher, mitigated by 1 week half-life and once daily dosing, several treatment doses, patient compliance with dosing conditions. So SNAC is an enhancer that facilitates absorption. The available data for semaglutide co-formulated with SNAC support that absorption takes place in the stomach in a localized buffered environment, and the effect is strictly time dependent and occurs primarily via transcellular route. Absorption takes place in the stomach. You can see from this graph published in 2018, plasma semaglutide concentration was measured by the liquid chromatography mass spectroscopy. The time profile confirmed early systemic absorption and apparent slow elimination once present in the systemic circulation. Absorption of oral semaglutide in stomach requires co-formulation with SNAC, and SNAC causes a local increase of pH, leading to greater bioavailability, higher solubility, and protection from proteolytic degradation in the stomach. And also the effect is time and concentration dependent and is fully reversible. Approximately 1% is absorbed, the rest is degraded in the GI tract. Still, what you are getting, the exposure response relationship between the oral and the subcutaneous is almost similar. You can see both the graphs are getting superimposed. And why it is convenient for you? No dose adjustment regarding renal hepatic impairment, no dose adjustment in elderly, and low risk of hypoglycemia across the pioneer trials. That's what we have understood. When should it be taken? Take when you wake on an empty stomach, wake up and take your semaglutide tablet straight away with up to half glass of water. Wait for 30 minutes before eating, drinking, or taking any other oral medication. 1 month 3 milligram per day, then 7 milligram per day for another month. If you require dose escalation to get better glycemic control, you can get it to 14 milligrams per day. And very importantly, the missed dose, they should skip the missed dose and take the next dose as scheduled the next day. So that brings me to the summary of the presentation. peptides are indeed challenging compounds and require engineering to optimize their in vivo performance. So the SNAC has come as a, I can say, Santa Claus for these novo people, where it is combined with the semaglutide, and it basically protects the, it increases the pH and protects the semaglutide from proteolytic degradation. It also enhances transcellular absorption. There is a prolonged T half-life, there is a better stability, and mechanism of absorption is shown to be compound specific, transcellular, and without any evidence of effect on tight junctions. So oral semaglutide, we all have been looking forward. The trial, if I recall it properly, it was published in NEJM in 2019. And we all have been waiting eagerly. It represents an advancement in treatment possibilities for chronic diseases by transforming injectable therapies to tablet-based oral formulation. And as my previous speaker was also alluding to, it can be given in a wide array of patients, including the elderly, patients having hepatic and renal impairment, without much issue of hypoglycemia. And the biggest strength is that we all are very much tuned to the advantages of GLP-1 as agonist, weight gain, the hypoglycemia, the cardio, the spectrum of cardiorenal protection. But then the injection was the main barrier. That barrier is significantly getting addressed by this wonderful molecule. Thank you all for the patient listening. Over to the organizers.
Taking Rybelsus properly is important for adequate absorption. It must be taken on an empty stomach with a sip of plain water. Rybelsus is co-formulated with an absorption enhancer that works to locally buffer the acidic pH of the stomach and increase transcellular absorption. Waiting less than 30 minutes or taking with food, beverages, or other oral medications will lessen the effect of Rybelsus by decreasing its absorption. Waiting more than 30 minutes to eat may increase the absorption of Rybelsus.
Thank you, sir. We would come back with the questions and queries at the end of the session. In the meantime, let us